and get started. I would like to welcome everyone to Radiologic Manifestations of Pediatric Tuberculosis webinar. If you should have any questions during this presentation that's pertaining to Dr. John's presentation, just please leave those questions in the Q&A box. All questions will be answered at the end of the presentation. And I'm going to go ahead and jump right into introducing our presenter for today. Let's see. So Dr. John is a specialist in diagnostic imaging of pediatric patients. Her other specialties include radiography, fluoroscopy, ultrasound, CT, MRI, and nuclear imaging. She is a professor of radiology and pediatrics and is the current chair of the Department of Diagnostic and Interventional Imaging at the University of Texas Medical School in Houston. Dr. John is a member of the Texas Medical Association and recipient of the John S. Dunn Distinguished Chair in Radiology. Would everyone please welcome Dr. Susan D. John.
Thank you, LaShonda. I'm sharing my screen here. And welcome everyone, and thank you so much for inviting me to speak on this topic, which has always been of interest to me. I think pediatric TB presents some special challenges for diagnosis that radiology can really help with. And so we're going to talk today about some of the characteristic findings that we see on imaging, how we can distinguish TB in children from other conditions that might mimic it. And I'll talk a little bit about how you can use advanced imaging to really help you solve special problems in these patients. So of course, primary tuberculosis is the main thing that we're talking about when we're talking about TB in children. That's the most common form, and it can affect almost any body system, but the chest disease is the most prevalent and what we're usually looking for first. We have many imaging tools in our armamentarium that you can use, and plain chest radiographs continue to be the mainstay of our imaging for children. But once you are worried about TB outside of the chest, then other types of advanced imaging really become very important. And we'll show some of these examples of when that can be really useful to you. Primary TB in the chest, the imaging findings really reflect what you know is going on with TB. It starts with a small focus, the Ghosn focus in the lung, which quickly drains to the regional lymph nodes. But can be progressive and can spread either by intrabronchial spread, hematogenous dissemination, or actual direct penetration of the pleural space or the pericardial space. And all of these things can have manifestations on the chest radiographs. Chest x-rays need to be of good quality, of course, and I'll show you some examples of when they are and are not. In terms of the actual pulmonary focus of TB, that's the less likely finding that you're going to be looking for, because that primary focus tends to be small. It can enlarge, but often it's very small. Often it's very transient. Sometimes it's hidden by the cardiomediastinal silhouette or other structures in the chest. And so you actually often don't really see that primary Ghosn focus. It may cause a little bit of mild pleural reaction, but usually pleural effusion is not a major contributor in primary TB. So this is an example of what a Ghosn focus can look like. You can see it's really a very ill-defined small area, and it would be hard to distinguish that from a little bit of atelectasis, which is also quite common in children's lungs. And that will only last sometimes for a few days and then will go away. And so you shouldn't really hang your hat on trying to find the actual pulmonary focus of primary TB. In other cases, it can expand, particularly if the child develops progressive primary TB, and so you can get a larger area of consolidation, and those areas of consolidation can actually extend all the way to the region of the lung hilus. And so, if there were to be hilar lymphadenopathy here, it might be difficult to actually see that because of the larger area of consolidation. This type of airspace disease. You wouldn't think of TB right off the bat in a child. You would probably be thinking of your more garden variety bacterial pneumonias in many cases. And so without that lymphadenopathy to help you, it may not be an easy thing to distinguish from a community-acquired pneumonia. So lymphadenopathy is really the key for us. It's really the hallmark of primary TB on chest x-rays. And it will be visible in a majority of cases sometime 1 to 3 months after the initial infection. We see it much more commonly in young children under 3 years of age, but even then we only see it about 50% of the time. In older children, it's much less common. And unfortunately, lymphadenopathy is not that easy for radiologists to always see or even agree about whether it's there or not. It's difficult to see, and so I'm going to admonish you if you're looking for TB, although we have a tendency to only get single view chests when we're screening for TBs in large populations. I think in children, it's really pretty critical that you get both PA and lateral views to help you view that hilum optimally. And you're going to be looking largely in either the right hilar or the paratracheal regions, which are most visible. So the lung hilar are here. And that's really where you're going to expect to see lymph nodes because normal lymph nodes, if they happen in the chest, are really not visible on a chest x-ray. So you're going to be looking for masses in the hilar region. And then the other place that they can commonly occur and be visible on a chest x-ray is in the right paratracheal region. So these are the two places where you should really look for an unusual amount of soft tissue density that you don't see in this normal chest x-ray here. And you're wondering, well, how do I know if these things that I'm seeing here are lymph nodes or not? Well, these are all vascular markings. So you do have a lot of vascular markings, and sometimes the blood vessels can be quite prominent and can make you wonder if you're dealing with a small mass there. But what lymphadenopathy will do is it will fill in this space here. So you should have a V-shaped configuration to your vascular markings in the hilar region. So if you can assure yourself that there's no lump sitting here in the middle of your V, then you're probably not looking at lymphadenopathy. You're probably simply looking at vascular markings that spread out from the hilar region. So compare that to this patient where you can see that there's a lot of fullness in that right hilar region. You no longer have that concave configuration between the vessels that are coming out. So this is the kind of finding that would make you think that you might have lymphadenopathy in the hilar region. This is a patient, slightly older patient, and you see that both hilar regions look a little prominent to you, right? On the right side, you have something that has a convex contour. So it really does have a rounded contour to it, much different than that V-shaped concavity that I showed you on the normal chest x-ray. Now on the other side, you're asking yourself, well, is that really V-shaped or not? But I think if you draw some lines, you can convince yourself, yes, in actual fact, there is some concavity there. So this is hilar lymphadenopathy on the right. That's all just vascular markings on the left. But you can see how challenging it can be in some cases to really have certainty about whether you're dealing with lymph nodes on the PA view only. So we liberally use our lateral chest x-ray to help us decide whether, because if there's lymph nodes there, you should really be able to see them on both views. Now, be aware that the pulmonary artery, which is that circle that I have indicated there, lies anterior to the carina, sort of in the region where you might expect lymph nodes to rise. So any rounded density that you see in the location of the main pulmonary artery, you should ignore. But if you have additional density, as we do here, a rounded density in the hilar or subcarinal region, then you know that that lump that you saw on the right side on your PA view actually is lymphadenopathy. The other place where you might see a mass that could be lymphadenopathy on the lateral view will be in the retrotracheal region back here. We don't have that in this particular patient, but that's another place where lymphadenopathy can show up on the lateral view. So this is just a comparison of a normal child, and you can see on the left that there's a clear space here in the infrahilar region, so there's no lymph nodes, as compared to the patient on the right, where there's definite soft tissue density in that infrahilar region. So that's subcarinal lymphadenopathy that we're looking there. This is another child, and this is a problem we get into if there's thymus gland in a child that'll sit over the hilum and make it difficult for us to see, particularly if the patient is a little bit rotated on the x-ray, which is not uncommon with squirming children. And so is that lymphadenopathy or not? But when we look on the lateral view, we can see behind the trachea that there's definitely a mass there that you wouldn't expect to be there. So this is right hilar lymphadenopathy, verified by your lateral view. This is another child where at first glance, you might not really think that there's any lymphadenopathy here, but recognize that the left lung hilum is much more difficult to see than the right lung hilum because the main pulmonary artery sticks out here. You might have some thymic tissue here in young children. And this is a rotated image, but if you straighten that child out, you can see that you actually do have a convex opacity there in the left hilar region. So having a well-positioned film with a good degree of inspiration and having a lateral view is the key to really being able to see lymphadenopathy successfully on chest radiographs. And even then, it can be somewhat challenging. So CT, of course, does better. So studies have showed us that, when you have a normal chest x-ray, up to 60% of those children with TB might have lymph nodes on a CT or for a variety of reasons, not just TB. So should we be doing CT on all these cases? Well, we don't really believe that that's warranted, but we do feel that CT can really help you in cases where you're suspicious that you have lymph nodes from your chest x-ray, or you have a very high risk group and it's extremely important for your management decision to know for sure whether you've got lymphadenopathy, then CT can be a useful adjunct. If you're going to do CT of the chest looking for lymphadenopathy, you absolutely have to use IV contrast. Non-contrast CT of the chest, just everything mushes together in the mediastinum and you won't be able to distinguish lymphadenopathy from the heart and vessels. High resolution protocols might be helpful if you're looking for fine detail in the lung itself, but it's pretty hard to do high resolution CT on young children. So you can order it like that, but whether or not you'll be able to get a high resolution CT of the lungs on a 6-month-old is pretty debatable. So this is just an example of what you get if you do a chest CT without IV contrast. You can see there's a lot of stuff going on in here. You can't tell what's what in there. So you must have IV contrast for these chest CTs. What about MRI? Because we worry about CT and having a slight, somewhat higher, exposure to radiation in young children. And there are some uses for MRI, and it can be useful for looking for lymphadenopathy. Generally, your lymph nodes have to be, close to a centimeter, at least 7 millimeters in diameter to really be easily visible on MRI. You might see a consolidation in the lung, although MRI is really not great for lungs in itself. And pulmonary nodules definitely have to be of significant size to be able to see them on MRI. So we don't really use MRI all that often unless we have an overwhelming reason why we don't want to give IV contrast, then MRI can be more useful. So where do you look on a chest CT? Well, the places where lymphadenopathy occur can be multiple. The most common site is in the subcarinal region. Bilateral hilar disease is quite common as well, but you can see them in the anterior mediastinum, in the right paratracheal region, and often you'll see them in multiple sites in the chest. Remember that young children will have this thymus gland anterior to their great vessels here. So we don't want to mistake that for lymphadenopathy, although that is a site where lymphadenopathy can occur. But more often you're going to be looking here in the subcarinal region. So here you can see the main stem bronchi coming off, and this is a lump of nodes in the subcarinal region. You'll be looking in the lung hyla here, adjacent to the pulmonary artery, and in the retrocaval or paratracheal region. Notice that these lymph nodes have a fairly characteristic appearance to them. They are low density in the middle, and they have some enhancement around the outside. It's not very well defined enhancement. It's sort of hazy enhancement, and some people have called it ghost-like. Doesn't look like a ghost to me, but it basically means that it's faint peripheral enhancement. But that is not necessarily pathognomonic, but is quite characteristic for tuberculous lymphadenopathy, both in the chest and in the abdomen. Size criteria for abnormal lymph nodes in the chest in children is not really very well established, but generally we consider a lymph node that's a centimeter or greater to be potentially abnormal. And these lymph nodes, of course, may continue to enlarge for a while. So you don't necessarily want to follow these lymph nodes with imaging to help you in any way. Once you've identified that they're there, that's probably the best information you can get from them. So the low density center with an enhancing rim is quite characteristic. You may see calcifications in children. They do occur, but often there will be no calcifications in the earlier stages of primary TB. Calcifications have to be pretty prominent for them to be visible on plain films, because there's a lot of dense things in the chest and in the paratracheal region. They are seen much more easily, of course, on CT. And you really only start seeing them about 6 months after infection in children. And certainly in young infants, you hardly ever see any calcifications. But they do crop up a little bit earlier in young children than they actually do in older patients. So this is just a patient. You can see this kind of streaky, dense area in the lung in this patient, which is characteristic of an area of atelectasis. And it's a little bit hard, it somewhat masks what's going on in the hilar region in this patient. But with CT, and here we used bone windows, which will accentuate calcium, and you can see that there's actually a mass in the hilar region that has multiple dense, small punctate calcifications within it, characteristic of the calcified lymphadenopathy that occurs in some children. This is obviously an older child. Once again, it can be really hard to decide whether you've got paratracheal or hilar lymphadenopathy in young children because of thymus gland. And so if it's really important to know, then the CT can really help you. Here, this is a paratracheal lymph node that was really hidden by the thymus gland on the PA view of the chest. And you can see the peripheral early calcifications and areas of enhancement within this lymph node. So we use CT in a limited way at this point, but understand that CT is getting better, and the doses that are incurred by chest CT in children are starting to become low enough that they're approaching what you might get with a chest X-ray. And if that actually comes to fruition, then we may use CT much more liberally in the future. Lymphadenopathy can cause other complications. Certainly it can press on the airway and it can lead to atelectasis or obstructive emphysema if it's only causing a partial obstruction of the bronchus. We tend to see that more on the left side than the right side. You can also have endobronchial disease, which also can obstruct the airway. And so if you see airway obstruction, but you don't see lymph nodes, it still can be related to the tuberculous infection or primary TB. And then you can have the lymph nodes rupture into the bronchial system, and that's when the patient may incur endobronchial spread of disease and have more progression of their pulmonary disease from that mechanism. So it's often hard for us to distinguish small areas of density, whether they really represent atelectasis or not. Here you see sort of an ill-defined area that might be a gone complex, hard to know. Notice here on the lateral view that there's actually some bowing. This is the oblique fissure here. There's some bowing of that fissure going towards that density in the lung, which indicates to us that that's actually an area of volume loss. So atelectasis is not an uncommon accompaniment of primary TB, whether it's related to lymphadenopathy, compression, or just endobronchial stuff that's clogging up the airway. This is another child with really prominent hilar regions on both sides. So you can see clearly you would be worried about lymphadenopathy in this chest. This child underwent some treatment, but came back a month later with more respiratory distress and had this large area of opacity that developed in the left lung. Notice that the remainder of the left lung looks very radiolucent and large. So that's sort of the rest of the lung is overcompensating for this density, which is actually atelectasis, which has developed in a delayed manner, which is not unusual because the lymphadenopathy can hang around for a while and can continue to enlarge and to cause compression of the airway. A week after that, this child went on to have complete collapse of that left lung. So atelectasis can be progressive. So if you see atelectasis in the lung, you shouldn't just write it off. You really do need to monitor that patient and make sure that it doesn't progress. Obstructive emphysema may be a little harder to tell. This is a child, you can see that there's some prominence in the left hilar region, which is some left hilar lymphadenopathy due to TB. Once again, notice that this lung is radiolucent compared to the other lung, and that's because you have some partial compression of this left main stem bronchus. You can actually see the narrowing of the bronchus here. So airway compression is actually much more common in young children. And so if you have airway compression and you see lymphadenopathy, then that's a very strong association and it should very strongly suggest tuberculosis to you, even though obstructive emphysema and atelectasis is extremely common in children for many, many other reasons. So once again, the lymphadenopathy is the key to drawing that conclusion, but you may or may not be successful in seeing it. So so we don't always agree as radiologists about these findings when we see them. Post-primary TB is much less common in children, and we see it largely in our adolescent population or our immunocompromised children. It's got the same findings basically as what you would expect to see in adults with post-primary TB. It's generally apical and posterior and may lead to cavitation and fibrosis and other complications of pulmonary disease. And I don't think you really need a CT to make the diagnosis of post-primary TB off of this chest x-ray, but I think it does provide a nice demonstration of the multiple small granulomatous lesions, the interstitial changes that may be early fibrosis, and these large, very thick-walled cavities that are quite characteristic of post-primary TB. But be aware that cavities can also occur in younger children in the progressive forms of primary TB. So they usually occur within a consolidation. So with progressive primary TB, you may have a consolidation that as you follow it begins to develop some internal radiolucencies. And here you can see that there's multiple areas of cavitation within this area of consolidation. And those may persist over time, or those may actually resolve or become less apparent over time. Because the other phenomena that can also occur that looks very much like a cavity but isn't really a true cavity is that obstruction of the terminal bronchioles can cause small focal areas of obstructive emphysema that we call nematoceles. And you can distinguish a nematocele in some cases by the fact that they have a very thin wall, not the very thick-walled cavitations that you tend to see in the post-primary tuberculosis patients. And nematoceles generally will be transient and will be self-limiting and will resolve on their own. This was a child that we had that had a rare case of congenital congenital TB, and as you can see, had very extensive lung disease. And even though the patient was in the hospital for quite a while, at discharge continued to have these large areas that look like areas of cavitation. But really, to my surprise, when the child came back for follow-up 6 months later, they had virtually completely resolved. And so what you see early on may not be the permanent appearance for children when they have cavities or nematoceles related to primary TB. Hematogenous dissemination results in dissemination to various places, and in the lungs, it gives us the miliary form of disease. And milia are defined as nodules that are less than 2 millimeters in size, thus comparing them to millet seeds. They usually are very homogeneously distributed throughout the lungs. You can faintly see them here because they are so small. They can be somewhat difficult to really see on a chest radiograph unless you have a really good resolution and not much patient motion. Some children will actually have nodules that are actually larger than 2 millimeters. So in older patients, they should be less than 2 millimeters, but young children can have miliary disease that has larger nodules. And here you can see a patient with slightly larger, these are close to 2 millimeter nodules, I would say, but they're quite apparent. But in addition to that, you have calcified lymph nodes, you have some granuloma in the lungs, all of the characteristic appearances of disseminated miliary tuberculosis. CT is going to be give you a much more elegant definition of tiny nodules, especially if they aren't very numerous. So this can be an application where CT can be very useful. If you're thinking you may have miliary disease and your chest radiograph is just indeterminate, then a chest CT. And if you can accomplish a high resolution CT, that's good. But most of the time, just a regular old CT using the lung windows will show you these tiny nodules. And this is just a child that has miliary disease, but it's much larger than 2 millimeters. So you can see all of these nodules are up to 4, 5, 6 millimeters in size. So that still is going to be miliary TB until proven otherwise in children. Small nodules, if they're extremely numerous, can really squeeze down the airspace so much that you have almost a diffuse, opaque appearance to the lungs. And so you can sort of imagine that there's small nodules here, but really it almost looks like a pulmonary edema pattern in the lungs. So that can also fool you. And so that's another time that CT might be really useful for determining whether this is really nodular disease or not. When you have endobronchial spread, you can get a pattern that is quite characteristic for progressive TB in the lungs, and that's been termed the tree and bud pattern. So you can see here, and it's much more easily seen on a CT scan. It's really a CT finding. You can't tell that it's trees and buds on your chest x-ray. You can guess that maybe there's some nodularity to it on your chest x-ray, maybe kind of a lace-like pattern. But on your CT, you can see that you have these centrolobular nodules that have branching densities that come out from them that make it look kind of like a tree in bud. And that's that's a good finding for springtime, right? And this is generally seen with endobronchial spread, not necessarily hematogenous dissemination. When primary TB becomes progressive, then you tend to have much more extensive lung disease, and it can be quite devastating, actually. You can see on this chest x-ray, it's pretty hard to tell from the x-ray exactly what's going on here. You can guess that there's probably some atelectasis because the mediastinum is sucked over to the left side. You can't even really see the heart to the right of the spine. So you know you have some atelectasis, but CT helps you to divine some of the other characteristics here. And with this form of TB, you can get fibrosis, you can get lymphadenopathy that persists. And so contrast enhancing, peripherally enhancing lymph nodes become much more easily visible on CT. You would never see them on your plain film. And you can also get cavitation and even bronchiectasis in these patients that CT will help you diagnose. Extension into the pleural pericardial spaces is uncommon, particularly pericardial effusion, which we probably only see 1% of our cases. Pleural effusions are a little more common, and they can occur either due to obstruction of the lymphatics or perhaps a secondary transudate that's related to a hypersensitivity reaction. You can tap these, but generally you're not going to culture anything out of them, so that usually isn't particularly profitable. Pericardial effusions tend to either occur due to direct extension from your mediastinal lymph nodes, which then involve the pericardial space, or to hematogenous spread to the pericardium. And so we tend to see these pleural effusions as a little bit of a later finding, and it's not unusual for them to be completely asymptomatic in these patients, even when they're quite prominent. So they can be very alarming. If you have a unilateral pleural effusion, of course, your first thought in a child is always bacterial pneumonia. But if you can actually see lymphadenopathy in the chest, then that's going to help you to narrow down your possibilities to possibly TB, as we have with these subcarinal nodes in this young child, which you would never guess from your chest x-ray. These pleural effusions don't always require treatment. They can be self-limiting, and so you don't necessarily need to stick in chest tubes to try to treat these, but it can be alarming finding on chest x-ray. Ultrasound, of course, is a very good way to look for a pleural effusion. So if you know you have TB and you know that they've developed a pleural, or you suspect they've developed a pleural effusion, then ultrasound might be your better study to use if you aren't really that interested in seeing what's going on in the lung in that patient. In terms of extra pulmonary spread, there's a wide variety of places that it can go. And of course, the brain is a place that we worry about maybe more than most. We mostly see this in young children. It's much more common in young children, particularly under 2 years of age. And almost always, if you've got central nervous system involvement with TB, you're going to have an abnormal chest x-ray. So it's really unusual not to see some findings of TB on the chest. Generally, this is going to be the result of hematogenous spread, and it can spread from a variety of places, but often it spreads from places that are close to the brain. So from skull involvement, middle ear involvement, and CNS involvement can take many forms. It can give you brain parenchymal disease. It can involve the dural spaces, the meningeal spaces. It can clog up the vessels and give you infarcts, or it can clog up the CSF pathways and give you hydrocephalus. Hydrocephalus actually can occur rather quickly particularly after meningeal infection. And so you should monitor carefully for that particular complication in children. Localized disease in the brain, most often we're looking for little focal infectious lesions, infected lesions, which we call tuberculomas. And you're going to be successful in seeing these using almost any kind of brain imaging. You can use ultrasound in young kids, but I would really recommend CT or MRI because the lesions take on a very characteristic appearance on those studies. You'll once again want to use IV contrast anytime you're looking for any kind of inflammatory brain problem. You should use IV contrast, and that will show you some small nodular lesions, often multiple, and they can either have a ring enhancing appearance, as you see with these lesions in the cerebellum in this child, or they can actually enhance homogeneously and appear like solid lesions. They're generally pretty small, less than 2 centimeters in diameter, and hardly ever do we see calcifications in the brain tuberculous lesions. TB meningitis is unfortunately quite common, and usually it gives you a diffuse type of meningitis. CT is fairly successful at suggesting this, although it's not 100% visible. Usually when we're doing a CT of the brain initially on patients, we're looking for bleeding, and so we tend to do a non-contrast CT. And fortunately, you can actually see some findings on non-contrast CT that would suggest tuberculous meningitis. But if you give IV contrast, it's going to give you much better delineation of that meningeal enhancement that can be very profound with TB meningitis. And the findings on MRI are actually very similar to what you would tend to see at CT. So this is a non-contrast CT scan in a child with TB meningitis. And notice that the gray matter is a little bit dense, the white matter is not dense. And you can see that you can actually see the area of the circle of Willis around the center of the brain, which normally on a non-contrast CT would be very low in attenuation, and it would not really stand out to you that way. So this is a feature of this very thick gelatinous exudate that is seen in the base of the brain and in the basal cisterns that actually can be visible without IV contrast. But once you give IV contrast, then you will see this very profound enhancement of the meningeal spaces. And it's easier to see in the parafalcine areas and around the base of the brain than it really is around the peripheral portions of the meningeal space. So that's really where you should look if you're looking for that type of TB, tuberculous enhancement. And there aren't many types of meningitis that really give you this a profound degree of enhancement. This is a T2 weighted MRI image without IV contrast, and you really don't see much on the non-contrast enhanced images with MRI in many cases. So the gadolinium, use of gadolinium is really pretty important if you're going to use MRI looking for TB. And once again, the finding is pretty much the same as the CT. You're going to see very profound enhancement around you kind of get this tram track appearance with the vessels outlined by very severe enhancement due to the inflammatory condition. You can also see enhancement in the spinal canal and in the along the meningeal surfaces of the spinal canal. It often, once again, is because this is a very thick inflammatory process. It gives a very nodular appearance. So perhaps you can appreciate here many tiny nodules along this enhancing stripe of enhancement along the dural surfaces of the spinal canal here. And that's you could see that with meningeal carcinomatosis, so it's not specific necessarily for meningitis, but in the proper clinical setting, it tells you that you do have meningitis involving the spinal canal. And then the other dreaded complication besides hydrocephalus would be brain infarcts, and they often occur in the basal ganglia and in the thalamus, but you can also have them in the parenchymal regions and the subcortical white matter, and that's what these areas are outlined by the arrows here. And so this exudate that involves the brain and the inflammatory process can cause some fairly severe disease, but it may just be small vessel occlusions, not major arterial occlusions. And so the areas of infarct may be relatively small and scattered. In the abdomen, we do occasionally see abdominal involvement in children with primary or hematogenetically disseminated TB. And you can see a variety of areas of involvement. Certainly lymphadenopathy, once again, is one of the primary findings that we tend to see in the abdomen, but the tuberculous lesions can occur in the solid organs. It can involve the peritoneal surface, which will have a tendency to give you ascites. Bowel wall is a pretty rare occurrence in children in my experience, but can occur, and you may actually get big masses of inflammation and even omental thickening in the abdomen. Lymphadenopathy tends to be in the periaortic or mesenteric region, or perhaps in the periportal region near the liver, and as opposed to or like the chest lymphadenopathy, it calcifies. It probably calcifies more commonly in the abdomen than it actually does in the chest. This is a chest x-ray on a 12-year-old who came in with night sweats, some characteristic general symptoms that suggested TB. You can see on her chest x-ray, the findings were pretty nonspecific. She had what looked like a little bit of a pleural effusion on this side. There was maybe a little atelectasis in the lung, nothing that really stood out as lymphadenopathy in the chest, but because of the back pain and the weight loss, a CT of the abdomen was performed, and you can see these multiple variably sized lymph nodes with the characteristic peripheral rim enhancement that is so typical of TB. So once again, not entirely pathognomonic, but really seldom do we see this much lymphadenopathy related to other types of inflammatory conditions in children, and it almost never has this type of rim enhancement. Certainly you could think of things like a lymphoma as well, but TB would be a good bet for this combination of findings in children. Solid organ disease, you can actually see with ultrasound, and so this is one of the areas where ultrasound may be a useful tool. Often in the liver and spleen, the lesions are quite small. They can be either micro abscesses or small granulomas that tend to show up as very small hypoechoic lesions, as you can see here. There's one here, but there are multiple small areas here giving you sort of a salt and pepper type of appearance. You're only going to see this if you really use a high frequency ultrasound transducer, which isn't always what's used on a general screening abdominal ultrasound in children. So I think if you know that you're looking for solid organ disease in a child related to any kind of granulomatous disease, including Bartonella, but particularly TB, then let your radiologist know that you really need some high resolution, high frequency images, because these can be missed if you don't use a transducer that has a frequency that's 10 megahertz or higher. And TB peritonitis, fortunately, is rare. In children, it tends to be the adhesive form of peritonitis. So often with ultrasound, you will see multiple septations extending through this. And it has a tendency to cause a lot of matting of the bowel. So you get these sort of amorphous matted masses that are just large areas of matted bowel. There's nothing otherwise, though, very characteristic about the ascites that we see in these children. So you really have to have other findings in the patient to really know if this is your initial finding, whether really this is related to TB or not. But I've seen very few cases of TB peritonitis in my experience. Skeletal TB is the last area that we'll really address, and this is also fairly uncommon, but we do see occasional cases of skeletal involvement in this country. I think it's much more common in endemic parts of the world that TB is endemic. Once again, it's generally of hematogenous origin, and often we don't ever find out where the primary site was, because there frequently is not any evidence of TB in the chest when you have skeletal involvement. The involvement of the bone undergoes a fairly regular course, starting with a granuloma, which then becomes caseating, then destroys the trabecular structure of the bone, can move into the cortex and give you cortical destruction, and can eventually give you periosteal reaction and can extend into the soft tissues. So the appearance can be quite variable depending on how extensive the disease actually is. Probably the most well-known site for tuberculosis involvement is in the spine, and it probably is one of the more common places that we see. In general, although you can have many different kinds of osteomyelitis of the spine, if you see profound paravertebral collections associated with destructive bone lesions in the spine, you should think of TB, because profound, large epidural empyemas are not that common with bacterial types of osteomyelitis. Also, usually with TB, you're going to have multiple contiguous vertebrae that are involved with the destructive lesion. So it usually won't just be one vertebral body. It can be two or more. Because this infection spreads both across the disc space, but it can also spread under the ligaments to give you these inflammatory masses. Usually we see it in the destruction in the vertebral bodies. You won't see it so much in the posterior elements of the spine. So if you see it in the posterior elements, you may be dealing with some other kind of entity. And this is just a child with fairly advanced tuberculous spondylitis. Fortunately, we catch it usually a little bit before this in this country. You can see there's multiple calcified lymph nodes in this patient. You can see the paraspinal collections show up as a mass on your x-ray. And on the lateral view, you can see that there's very extensive destruction of these vertebral bodies, which can occur. And if you get more than about a 50% destruction of a vertebral body, then you can get this angular gibbous deformity that can give you a severe kyphosis that can actually be quite deforming. Fortunately, young children, if they get tuberculous spondylitis, have great regenerative capabilities in their bones. And so actually they can heal their spinal lesions, and they may not end up with permanent deformity from this. But older children and adults have much more long-lasting deformities that can be the result of TB in the spine. TB can involve the joint spaces, and this is probably the second most common place that we tend to see musculoskeletal involvement in children. And unfortunately, there's nothing very characteristic about the imaging findings for it, but they will present as most arthritides do with a joint effusion. Most of the time, it's just one joint that's involved, and we most often see it in the lower extremities in the large joints, either the hips or the knees. Ultrasound is a good way to screen for any joint effusion, particularly at the hips, where we don't really have good ways of seeing that on plain film. So here you have the femur here you have the joint capsule and the iliofemoral ligament, and all of this in here is joint fluid that's bowing the joint capsule anteriorly. So if you have a child with known TB, you think that they have joint involvement, then ultrasound is a good way to screen for that. You might not need to do any more elegant imaging than that to tap that joint and to treat it. But osteomyelitis is going to require radiographs and other types of imaging. It's also pretty uncommon, and most often we'll just see a solitary area of bone involvement. in children. It's usually not multifocal. Often once again, we don't tend to see any pulmonary disease. So if you have a child that comes with a lesion like this, you wouldn't necessarily know right off the bat that you're dealing with TB here. These are not rapidly progressive bone lesions, and so you'll see some sclerosis around the edges, which would suggest to you that it's a more non-aggressive, even benign type of a lesion, but you wouldn't know that that's not a bone cyst or an indolent form of bacterial osteomyelitis in a child just from looking at it. We tend to see them commonly in the long bone metaphyses, but they're also quite common in the skull. You can see a dactylitis in the hands and feet, which is pretty characteristic of tuberculous osteomyelitis, and occasionally you can see it in the ribs, in the chest. The patterns of involvement are usually they're going to give you an osteolytic lesion, like we saw in that femur, usually with some peripheral sclerosis and a mild degree of expansion of the bone, not a profoundly expansile lesion. But occasionally they will have a very infiltrative pattern that will make the bone look somewhat what we call moth-eaten, because it has multiple small areas of destruction, and that might suggest other types of destruction, even tumor like a Ewing's sarcoma. So that can be very confusing if you have that type of tuberculous bone involvement. And then the dactylitis that we know is spina ventosa, of course, tend to see that in young children, and that's a fairly characteristic pattern for TB. So it can also involve bones that you don't really expect to see osteomyelitis in very often. This was a chest x-ray that was done in a patient that was suspected TB. Didn't really see much in the way of lymphadenopathy, but on the lateral view, there was some thickening of what looked like the pleural space behind the manubrium in this patient, and a CT scan was performed, and you can see there was actually rather remarkable destruction of the sternum with low density collection involved and some peripheral enhancement. And this actually was shown to be TB of the sternum without any other intrathoracic evidence that we're really dealing with CT. So you can see how TB can be very confusing when it gets outside of the chest. And the last area is really skull involvement. That's a vast minority of cases, but still it is one of the common things that we see more in children than in adults. And usually you'll have significant bone destruction, but you can have both extraosseous and intracranial extension of the area of exudate. Most of the time you're going to have some subgaleal swelling, so you're going to clinically be able to tell that you've got something going on in the skull. CT can be quite helpful in making sure you don't have significant intracranial involvement that's associated with that skull TB. So this really covers, it's a pretty broad overview of what happens in children and how we approach our imaging. You can see that the imaging is quite variable, and although there are some pretty characteristic findings in the chest, many of the findings are nonspecific and sometimes quite subtle with just plain films alone. Looking for that lymphadenopathy is really key because we don't tend to see profound lymphadenopathy, even though you can get lymph nodes in children with bacterial infections. It's really, if you see hilar or paratracheal or mediastinal lymphadenopathy, one of the first things you should think of is primary TB. And certainly CT and MRI and ultrasound can all be helpful to you, but aren't something you want to automatically go to. Only use it for questionable findings on your chest x-rays or for needing to outline more extensive extra pulmonary spread of the disease. So thank you for letting me speak to you on this, and I'm happy to entertain questions.
So we do have, well, first of all, thank you, Dr. John, for that very visual presentation. So we do have two questions in the Q&A box. The first question has multiple questions within one. So she asks, or I don't know if it's a she or he, for what ages of children do you recommend PA and lateral chest X-ray? Is 5 and under sufficient, or do you recommend 2-view for children, for older children as well?
I recommend 2-view for everybody. I think you can't go wrong with a 2-view chest. I think there are places where they feel challenged by doing 2-view chests on young children. We have this device called a pigastat, which not all radiologists use, but I think it's very useful because you can put the child in this device, put a plastic tube around their chest, put their arms above their head, and then you can position them very easily. But I think that the findings are so subtle, even on older children, that you're going to be better off just getting 2 views. The radiation dose from a 2-view chest X-ray is hardly more than a 1-view. And most of the time, a good technologist is going to be able to get you a good X-ray. And so I would recommend 2 views at every age.
Okay, and the second part is, would the recommendation vary depending on screening for school versus screening due to a known contact to TB?
Well, yes, obviously you're going to have a higher degree of suspicion if you've got a known contact. If you're doing a large population screening process, then that's when 1-view chests are usually utilized, and that practice is probably not going to change, particularly in adults. So I wouldn't argue with, if you've got to take a lot of chest X-rays on a lot of children in a short period of time, then you might be relegated to doing just 1 view of the chest. But if you have any other reason to have a higher degree of suspicion of TB, whether it be contacts or other symptoms, then I think you should probably do a 2-view.
Okay, and the second question is, was there right paratracheal adenopathy in 12-year-old with abdominal TB? I believe she's referring to one of the patients. Uh-oh. Dr. John? So it looks like Dr. John is having a little technical difficulty right now. Gonna just hang out just a second just to see if she can reconnect.
Hi, I think I lost you there.
Oh, there you go. Okay. Okay. No worries.
Did you hear my full answer to that question?
We did not.
Oh, okay. My answer to the second question was that if you're doing a large population screening of children, then it might be more expeditious just to do single view chest, so I can understand that. But anytime you have any other secondary reason for being concerned about TB, whether it be contacts or other symptomatology, I think you should probably try to do 2 views.
I'm sorry, Dr. John, was that the end of the first question?
That was the second question.
Oh, okay. Just wanted to be sure. If there are any more questions, please go ahead and type them into the Q&A box. And while we wait to see if we have any additional questions, I just want to mention that we will be sending out a sign-in form to everyone who registered for this webinar. The sign-in form is just for anyone who is viewing as a group. So if you are viewing with another person or more than just yourself, please fill out the sign-in form with everyone's name who is viewing with you. If you are viewing alone, you do not have to fill out that sign-in sheet. and I have not seen, oh, there we go.
I think there was at least one more question. And someone asked, was there right paratracheal adenopathy in the 12-year-old with the abdominal TB? I couldn't appreciate any on that chest x-ray. I think that was all vascular markings. Once again, it was kind of concave. And that was the second question. Do you want me to try to show
If
that
you would,
again? Let me try to show that image. Let me see. I don't know if I can, I've lost my ability to share the screen here.
oh, you did? Okay, let me see.
I think I can't see my Zoom window, so that's my problem. Let me see where my Zoom window went. I've lost my Zoom window.
Okay, let me pull it up for you.
Yeah, try to pull up. It should be slide number 58, might be 59 on your version. Oh, okay, no. Whoop. Can you advance to go down to the abdomen views? Yeah, go to about 58 or so. Yeah, keep going, keep going, keep going, keep going, keep going. There we go. One more. This one, yeah. So, so this is vascular marking. This is kind of a small image, but these are all vascular markings. But I can see how you might wonder about this, but that didn't really prove to be lymphadenopathy in this particular child. Although certainly they would be entitled to some lymphadenopathy in the chest as well. But the main finding on the chest X-ray was really the pleural effusion. So at first we weren't really suspecting TB until we got the CT.
Okay, so we have another question that says, okay, let me, I can't see my.
It looks like maybe it says thanks. Is it? Yeah.
It was one in the chat box, but I can't seem to get back to my chat box.
All I'm seeing is Dennis here asked about the paratracheal lymphadenopathy is what you're talking about. Yeah, so you were talking up here, but no, you've got azygous vein here, and you've got superior vena cava coming up here, but that's not really those are not abnormal markings.
There was a question in the chat box that says, do you recommend multiple chest x-rays evaluation during treatment?
Well, that's really not a radiologist question, I guess. I think, you should only get imaging if it's going to help you decide whether you need to change your management or not. So in my experience, we do tend to get, certainly if we see pulmonary TB, we do tend to get a follow-up chest x-ray at some time, but I don't have a sense of when that timing should occur. Or how often you should really do that. But in general, anytime you're treating any condition and you need a landmark about whether it's time to stop treatment and you don't have other types of markers to help you decide that, then imaging can certainly help you with that. And so perhaps the chest x-ray would be valuable, but I'm not sure because the changes in the chest x-ray findings occur rather slowly over time. I wouldn't recommend very frequent interval chest x-rays because you're probably not going to see a lot of change. And if you do see a little enlargement of the lymphadenopathy, that doesn't necessarily mean that your treatment is unsuccessful because that can just be the natural progression of the disease in many cases.
Okay. I'm not sure if there's another X-ray question. Do you recommend, oh, did you answer the periodic chest X-ray question?
Yes.
Okay, so there was a similar one in the chat box. Do you recommend multiple chest X-ray evaluation during treatment? But it looks like it's the same person.
Yeah, I think that was the question I just answered. Yes.
Okay, and there are no more questions coming in at this time.
Well, thank you very much. I enjoyed talking to you, and I'm easy to reach. If you ever have any cases that you have questions about, just send them to me.
Thank you, Dr. John.